Hello. The topic today is integrated care models, choosing the right one for your patients in your practice. And now, without further ado, I'd like to turn things over to your host.
Hello and welcome to Alliant Quality's Learning and Action Network for improving the identification of depression and alcohol use disorders in primary care. As Alliant Quality's Behavioral Health Task Lead, I would like to extend my appreciation to you for participating in today's event and your commitment to improving the behavioral health outcomes of the patients you serve. Before we begin with today's presentation, I would like to remind you that in addition to our free monthly webinars, we also provide free evidence-based tools, resources, and technical assistance to help you enhance your service delivery and operational efficiency. I encourage you to take advantage of these opportunities and to frequently engage with us to share your thoughts, experiences, and best practices. And now, it's my honor to introduce our guest speaker, Dr. Kathy Hudgens. Dr. Hudgens is the Executive Director at the Center for Excellence of Integrated Care. In her role, she is part of a team that works across the state and nation to promote successful, sustainable integrated care. As the integrated care professional, she is not only a generalist, but also specialized in integrated care, ethics, policy, and program development. Prior to joining the Center of Excellence, Dr. Hudgens gained experience in integrated care management and development, behavioral health consultant, crisis assessment, prevention, outpatient counseling, and community mental health consultant. As co-founder and prior director of Bradford University Center for Integrated Care Training and Research, she has also trained and developed integrated care systems and participated in research and grant writing initiatives. Welcome, Dr. Hudgens.
Quickly, I don't want to take up too much time on our objectives, but today that we're going to look at the two main evidence-based integrated care models. We're going to identify the basic core concepts of these integrated care models, and then we're going to discuss how each model addresses specific patient care needs in primary care. I do want to say, as you're listening to this presentation, it would be really helpful for you to think about the needs that you have and the questions that you have about which model to choose for your program, or if you're currently using a model, how it aligns with one of these evidence-based practices. So I'm going to start with leveling everyone with the definition of integrated care that we use at the Center of Excellence and the one that we have been sharing across the United States with our partners. So we use the C.J. Peak definition that came out in the ARC, which says that integrated care is care that results from a practice team of medical, care, and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care. And I think the key parts here to this to highlight is the fact that you are a care team, a team of professionals working together, sharing the patient responsibilities, and focusing on systematic and cost-effective patient-centered care. So why do we integrate? Just quickly, if this is not a question that you've contemplated, or maybe this is where you were thinking right now, the majority of people have comorbid mental health and medical problems, but don't receive any care consistent with established practice guidelines. And this was found at the Institute of Medicine. Now, effectively treating medical and behavioral health comorbidities require a team-based care approach, not that traditional siloed care, which is something that we've been using for a very long time, which means that providers are working, within their own practice areas and their scope of practice, but they're not collaborating and sharing the patient responsibilities. And then, so as we are really focusing on putting these behavioral health providers together with primary care, one of the questions we get quite often is, how does it work? Because to be very honest, if you just put two types of providers who have been traditionally trained together in one setting, they're going to probably do traditional care side by side. The other thing is that, they'll come up with some maybe processes that they'll have to test, and it takes a very long time to sort of refine these. The great news is, through these models, we have come up with evidence-based processes and practice protocols that really do make this a very streamlined, systematic way of putting these providers together in a team-based care environment. If you look at the sort of concepts underneath the team-based care, it assumes that health is a shared community responsibility, and that mental health and medical care providers do need to work together. Now, this is very important to coordinate the detection, which is that screening, so identifying the patient, the treatment part of it, and then the follow-up. And all three of those areas are very important in team-based care, because if you only have one part of that, then you really aren't working toward a total health, whole person care approach. You're basically doing some part of traditional care and then hoping that someone else will pick up the other parts. And then it is very strategic. And so we really want to look at the person's health needs and goals. And we do this on a continuum, so integrated care, starting from what we really do in traditional care, which is working very, far apart, siloed, all the way to working side by side in the room in real time, working with the patient as a team. So there are core concepts that we have developed over time that are reflected in the 12 domains of the integrated care lexicon. And so I just want to highlight those because we won't have time to go over those today, but most of them really do break down the individual domains when you're building a practice. Everything from where the providers are located within proximity to each other, all the way to administrative buy-in and processes within your own policies and procedures. So if we look at what happens in the practice on the ground, on the patient contact level, all the way to the policy and implementation side. So moving on to the models that we're going to talk about. And, I know I'm moving through this very fast, and again, these are very quick little webinars. But if you're interested in any of these aspects that I'm referring to that we are just sort of touching on, the literature and all of the references will be included. And I would encourage you to sort of peruse those if you're interested in that systematic development through the core domains. So the two evidence-based integrated care models that we're going to talk about today, there are actually a couple more, but these are the ones that you would find in primary care or some type of specialty medical care setting. The first one is the primary care behavioral health model, and that's the PCBH. That's what we call it in the field. In this model, the behavioralist is a generalist. So the behavioral health provider that is on site sees all patients who come through. So it's not targeted to one specific population. It's an untargeted model that really does look at all of the health care needs that have a behavioral health component to it. The behavioral health provider is in proximity to the medical provider and can be introduced and then work with the patient in real time. So that's called a warm handoff. The PCP, the primary care provider, is the first customer. So you really are there, the behavioral health provider is there to support the primary care team and the primary care provider. That is the behavioral health, health behavior sort of support. It's not you do your traditional care and you're only serving the patient. You're working with the PCP team. It mirrors primary care style in terms of pace and the number of patients seen, the brief interventions. It really matches the expectations that patients have of primary care, knowing that the providers who are working in that practice are talking to each other, exchanging information, working together to work with their patients. Just as we have in traditional care with PCPs working with their nursing staff and the lab staff and the front desk and the billing, the expectation is that the information will also be shared with the behavioral health provider working with the primary care provider. And we call this a horizontal model because it is across all populations and not targeted to a specific population or disease state. It's very much a population health approach. The collaborative care model, which had been actually coined as, had been actually called the impact model, but they've branded the model to be more inclusive. So that's a collaborative care model. It's registry driven, meaning that you identify a specific complexity of patients that would have comorbidities for medical and behavioral health problems. You set the threshold for that, so as the patients are identified with those conditions, those comorbidities, they are put on a registry and they are followed through medication and visit algorithms. In other words, there are some very clear protocols that would trigger through the registry follow-ups by a care manager or possibly a behavioral health person or a nurse manager who would be calling that patient to follow up. It's very disease-focused, so for depression and diabetes, for instance, those comorbidities would be very common, and actually it's been validated for depression in older adults with comorbidities, but there are current trials to sort of expand that validation to other disease states. And it's a vertical integration model, meaning that it's very targeted, it has a clear glide path to an outcome, they're measuring outcomes, and it's not, you know, sort of that whatever comes in the door, we're going to take care of it kind of approach. It also requires a consulting psychiatrist. So looking at, again, the PCBH model, we've already talked about this a little bit, it's population-based. If you look at this, you can see that in 1 year with 8 clinics, you can see 8,000 patients with about 19,000 visits. So you are really getting a lot of impact into your patient population. It's based on you know, a brief intervention, lifelong relationship with patients, not really looking at what we would consider long-term treatment. It's focused on functioning, so we're looking at helping patients function. We're not doing traditional specialty mental health that requires long-term, consistent weekly visits of 50 minutes. These are visits that are about, you know, can be 15 to 20 minutes long. And, you know, again, we talked about this, the behavioral health consultant is operating as a consultant. So why would we want the PCBH model? It's because we understand that folks are going into healthcare looking for their total health needs, and we know that healthcare includes, or total health includes, behavioral health. It improves the work life of the PCP. When we have a behavioral health provider in there, we can really get some traction in terms of reducing the amount of time a PCP is with a patient, especially if they have needs that a behavioral health provider can help with in the moment. It does increase the access, because a lot of times when a behavioral health issue or a substance use issue is identified, the patient is given a referral, and 1 out of 4 will go to that referral and the other 3 will not. So you get that in real time. And again, this is very brief. It's not, you know, looking at someone long-term, having a patient panel where you would end up with a wait list. The clinical gains are high because we're looking at health interventions that actually prevent many of the healthcare issues to exacerbate or deepen, and also the behavioral health issues are reduced as well. And then it does reduce the referrals to specialty care, which allows specialty care to be freed up for the folks who need that more intensive specialty mental health. Now, the collaborative care model is, again, disease-focused, registry-driven. So registries meaning not a legal pad with people's names on it that you have to remind yourself. We're talking about something that you would actually build into your EHR, so you would get some type of consistent follow-up that you could track, and then you use that data for outcome measures. It is a collaboration between primary care. It says case manager, and in this case, this is how it's written in their protocol, but you can also use another type of behavioralist, and then a consulting psychiatrist. Use medications, and again, this is for folks who really do need medications. For PCBH, you really are working with people that may not need medication. They don't necessarily need, that much of intensity of treatment where they would be monitored in their symptomology. And then you're looking at behavioral health, activation and problem-solving treatment as the key follow-up strategies, and then looking at your improvement by using the PHQ-9, which is a depression screening score, and then tracking that over time. And so as you're thinking about the model that works for your system, you might want to be thinking, do I have access to a psychiatrist? Do we have more people who could benefit by, more of that prevention and health behavior, and really looking at across a population approach as opposed to a more targeted approach? So the collaborative care model, again, we have some great outcomes with this. If you're looking at patients who do need medication, there's a 50% reduction in depressive symptoms at 12 months. And if you look at usual care, where people are coming in for their diabetes, they're not getting that depression medication and the follow-up, it's only about 19%. And then again, looking at how the interventions that are used with impact really do reduce over time the recurrence of major depressive disorder or other types of severe persistent mental illnesses. And then, looking again at the experience that, those 100 additional depression-free days, because we do know that there are many folks who will have depressive episodes that are recurrent, and we're able to reduce that. This is sort of a diagram to look at what we mean by the population horizontal approach as opposed to a very vertical targeted. And, you can combine these. And we've worked with quite a few sites that it's a stepped approach where if they do have the capacity to put both models in, they can have a PCBH model running for their general population and a targeted collaborative care model for their folks who really do need more intensive treatment. And it really does work very nicely together. So thinking about your practice and the decisions you're making about your model, what questions do you have?
We have a first question. What if we don't have access to a psychiatrist? What would be the best model for us?
That's something to really consider, because the protocol for collaborative care does require a consulting psychiatrist. So if you really do feel like that integrated care is something that your patients would benefit by, and you do have access to specialty mental health for a referral for those, once that patient may need to, receive some type of more intensive treatment, I would go with the PCBH model. There are some folks who will use telepsychiatry in their collaborative care if you do have some access to that. I know they're doing some research on the efficacy of that. But again, you do get a whole lot more if you have that behavioralist on site, and then allowing the medical provider to potentially, increase their capacity and comfort with maybe prescribing if the patient does need prescribing, since the behavioralist is there and can monitor symptomology and work with the patient.
Dr. Hudgens, what type of behavioral health provider would we want to hire?
Depending on your state. Now, we try not to build our services, especially for the PCBH model, based on what you can be reimbursed for, but the basic bottom line is that you have to pay for these services. So in most states, for Medicare, and in fact this is a federal guideline, LCSWs and psychologists can bill Medicare, and they're wonderful to have on site because they can work with the older adults as well as any of the other populations or anyone who is a Medicare recipient. LPCs, or whatever your state may call that, your licensed counselors, and then your licensed marriage and family therapists are great. Medical family therapists, so LMFTs that are MedFTs, are trained in medical family therapy, which is integrated care, essentially. So they're wonderful to have. And so now that's for the PCBH model. For the collaborative care model, you can get a psychiatric nurse, or a nurse actually, a nurse care manager, someone who really does understand how to run the protocols and do the screenings for the PHQ-9 follow-ups. So that's another one that would be really good. And then, if you have some associates, those are called A's in North Carolina. But if you have some folks who are working through their licensure and they're under supervision, sometimes you can use those as care managers, and they're really great because they're learning and they do have that extra level of supervision.
Dr. Hudgens, what would be the top 2 pieces of advice you would have for practices in selecting their model?
I would, a lot of people will start with billing. What can we bill for? And I would say don't do that. I would say, if anything, go back up a whole lot farther and look at the capacity and the goals that you have from your providers and your administrators. Because one of the things that we lose when we start adding these new standards of care is the reason why the providers got into this business in the first place. Ask your providers, what are you struggling with the most in helping your patients be well and healthy? And as they're talking about the behavioral health issues, thinking about what are those issues that they can't help them with, and what is taking up their most time. Are you working with patients who really do have those behavioral health needs and need that extra support? That's when you start building your program. I would also say I would look at the patient health needs through your data. If you have an EHR, start looking at your comorbidities. What are the top 5, comorbidities that you all are identifying or that you are aware of? And what would be the best way to address those through the capacity that you have in your practice, but also in your community? That question about your psychiatrist, do you have access? What else? How else can you address the medication needs? So those are, to me, that would be what I would say. I know people would want me to be more, build an EHR that looks like this, or use this EHR instead of that EHR. That's electronic health record. I'm so sorry if I'm using all my acronyms. But I really think it needs to back up even further as you're planning.
Dr. Hudgens, thank you for that excellent presentation, and thank you all for participating as well. Before you go, I'd like to remind you to fill out the post-presentation evaluation. Once that's completed, you'll be able to download your CE certificate. If at any time you have any questions or concerns, please do feel free to reach out to me at the contact information you see before you. I look forward to our continued engagement and to your attendance at our next Quick-N-R on January 19th. More information about this event will be sent out to you shortly. Until then, take good care.
Thank you for joining the call today. This is Dr. Adrienne Mims, Vice President, Chief Medical Officer for Alliant Quality. As you see on the slide here, there are some screening codes that you can use to document that you are doing screening for Medicare beneficiaries for depression. These are available to primary care clinicians as listed there below. And there are several codes that can be used to indicate screening. We've also listed the amount that are charged in various areas of your state. Please use these codes. You deserve the reimbursement, and it documents the quality care that you are providing. Thank you.